All right, welcome back, everyone, to another edition of Dermatology Grand Rounds, Psoriasis Edition. I am joined by the vivacious and lovely Melody Young, who is going to start us off with a psoriasis case. Take it away, Melody.
Thanks, Adam. Yes, so love psoriasis, spent my whole career
Who
treating it.
does it,
And
right?
yeah, and still see so many interesting cases and still love the new additions and therapies we have to solve old problems. So the case that I selected for this morning had to do with a long-term relationship I'd had with a patient as well. And had cycled through everything. I mean, she had even used methotrexate, in the early years. We had tried things when she had her pregnancy. We used cyclosporin because of the bit of, safety record we had. Literally gone through all of those things. And we could get her in pretty good shape with her psoriatic arthritis, but her if we did something that was great for psoriatic arthritis, didn't quite get her to that treat to target. We have 1% or less psoriasis. So always had a few stubborn areas, and they were really thick. Very, these are not superficial. These have a lot of induration. So we could break them up, as you can see in this photo, where you had sort of, it was a large plaque, and you can see a little bit in the perimeter of how the hyperpigmentation that was there, the amount of inflammation. She's Asian, and people, I think, with more darker skin tones are very much at risk for or hypopigmentation, especially with the amount of topical steroids. And also when inflammatory psoriasis or AD or any inflammatory dermatoses sits for a long time, that inflammation, even when it's gone, is going to be a problem. We even tried topical, or excuse me, intralesional triamcinolone, steroid injections barely under the skin, very dilute, 2.5, sometimes 5 milligrams, to try to see if we could break this up. But we never could get it clear. And this was on her back, and you can tell this is not an excoriation situation that has fed this. It's just always an issue. Okay, let me show you what happened with the progression of this lady. So I was always looking for what new thing can I add, can I try? And she was always up for that. Sometimes people would say, I've already tried that, didn't work. They were just so used to failure that when roflumilast came into the market, that was the only addition that I did. I kept her on the same other treatment and had her use it once a day because it wasn't a place that she could reach. They can't reach spots. Sometimes I have them put it on a cooking spatula, to try to treat it. And then just said, use it until it's clear. There's not a downtime like there has been with others where I'd say, with a corticosteroid or something used for a few weeks or a month. Just keep using it till you see me. And when she came back in, then I said, how'd it go? And she goes, I think it's gone. We looked, and it was gone. And you can see a little bit of the surrounding, a little bit of discoloration, but very, very minimal. And she thought it was gone. And I said, are you still using it daily? She goes, well, I kind of stopped. I'm not quite using it when I didn't think about it anymore because she didn't feel it. She didn't think it was there. So what do you tell patients? That's one of the first questions that I would have about continuous use of things like roflumilast, these non-steroid or these sort of advanced topicals. Do you have them keep going? Do you believe it keeps it from coming back? Do you think once it's clear, it's clear? What's
Yeah,
your thought?
it's interesting. I think it depends on the drug. So there's what's in the label, and that's what we tell patients, right? So I think it's important to recognize that if there are restrictions in terms of continuous versus non-continuous use, that non-continuous use is often related to how long the study was, not based on anything safety. And I think topical ruxolitinib is the greatest example. AD, it's 8 weeks on, then you got to give it a break. Vitiligo, it's months. It just has to do with how it was studied. And I think, this goes back to this point of this spot just never really got better, or maybe it's more, it got a little better, you pulled the steroid away and it got worse again. And that's such a common story of like, the medicine didn't work. Well, it worked when you used it, but you can't use it forever. And when you take it away, the disease comes back being a chronic disease. So I think the flexibility and the ability to actually apply something daily, and I'm totally with you. I like chronic use of these non-steroidals in hotspots that either A, never go away, or B, come right back. Now, if someone's full body, then you're probably stepping back and saying, we probably need a new systemic. But for those few areas, that 1 to 2% BSA that's just super stubborn, you know that area is always your, your difficult child. That's where I think something they can use not just as an active treatment, but also as a prophylactic treatment to prevent the buildup inflammatory infiltrate that creates what you see clinically. I think that that's a huge win for us now that we have options that not only are safe to use ongoing, but also probably have better efficacy than some of the more historic medications we've used.
Yeah, and I think just for clinical efficiency, rather than constantly changing from one biologic to the other and sort of never getting past that point that you can't get to that total clearance, I think it's great to introduce a topical to see if if it's always the same areas. Just let's try one of these things. And interestingly enough, she had been on an oral PDE4 inhibitor before, and it did not do this the way the topical did, which I wasn't really sure at the time. And I thought, let's try it. It's new and it worked. So I'm going to show you, just to put it in context with how the experience had been with topical other products. So you can see on her forehead the hyperpigmentation. This was, a few years earlier, in the amount of scalp psoriasis and facial psoriasis, and that post-inflammatory pigment change was very, very significant. So I was kind of expecting it, but did not have it with the roflumilast, which I thought was great. And clearly now she's a convert and probably will never use another topical corticosteroid, because when we we get the inflammation down and get the plaque to clear, this is more what we were getting. So I just thought from a comparison perspective, that was also a cool little side feature. Do you see this? Or I know it's always a worry with particularly non-Caucasians.
Yeah, no, I mean, I think if anything, an individual with a darker skin tone and propensity for post-inflammatory hyperpigmentation, often that hyperpigmentation is more disabling than the primary disease itself. And so what that really tells me is I'm actually going to be often more aggressive, not just in psoriasis. I think acne is another great example. I might reach for isotretinoin faster because of the potential risk for dyschromia. But, I think psoriasis is somewhat unique because it's not just plain old, post-inflammatory pigment alteration from picking or scratching, but there's actually some biological basis in terms of the inflammatory mediators and how they can induce melanogenesis as well. So I think that combination therapy, you and I have talked about this in the past, is so hugely important. It's not a one size fits all as well. And the fact that we have so many options that we're not stuck with one thing. If it doesn't work, too bad, you're SOL. Like, we actually can switch gears and try something different. But I think for a chronic disease like this, having something you can use ongoing for when it's there and even when it's not, to prevent recurrence that can lead to more pigmentary alteration, is so hugely important, and just makes our jobs a bit easier.
I agree. Tremendously effective for her, and she was very happy. And we use it now. If anything emerges, just put it on there, because we are yet to have a single drug that works 100% of the time on 100% of patients. And you're just always going to have to mix and match and, find personalize the care for that patient, what their goals are, what you need, and use everything. Don't just say, oh, I've got my one go-to therapy. Learn to use them all.
Yeah, be flexible is what I'm hearing.
Yeah.
And we can. That's the funny thing, is we now actually have the ability to do so, where that wasn't the case, even 15 years ago. So well said.
It's like being a master chef with all the ingredients and, getting to mix it up but make it specific and unique.